Welcome to Next Chapter Retirement, the podcast where we discuss smart strategies for building and protecting wealth, health, and well-being, helping retirees shape their next chapter into the best chapter. I'm your host, Mark Erickson, and each week we help you navigate the big decisions that shape your future, from health and financial planning to Medicare and lifestyle design and everything in between. Let's dive in.
Imagine paying the full retail cash price for a life-changing medication for 20 years.
Right. I mean, that's just a remarkably long time.
Yeah, and all simply because the government categorized your disease as a quote-unquote lifestyle choice.
Exactly.
If you were on Medicare and you needed a drug strictly for weight loss, you were entirely out of luck. The door wasn't just closed, it was locked by federal law.
Completely locked tight.
But as of July 1st, 2026, that door has suddenly cracked open for some of the most highly sought-after GLP-1 medications on the market.
It really is a watershed moment in American healthcare. I mean, what we are witnessing is a fundamental structural shift in how the Medicare system views obesity.
Oh, absolutely.
We are moving away from this outdated idea that it's a purely cosmetic issue or, a failure of willpower.
Right, which is huge.
It is. We are finally beginning to recognize it as a chronic, complex condition that requires serious medical intervention.
Okay, let's unpack this.
Yeah.
Because that shift is exactly the mission of our deep dive today.
Yeah, we've got a lot to cover.
We really do. We've got a fascinating stack of sources to work through. Everything from technical retirement planning scripts to official policy updates from the Centers for Medicare and Medicaid Services.
And some incredible data modeling from KFF as well.
Yes, exactly. So our goal is to cut through the massive hype surrounding GLP-1s and decode this brand new initiative they are calling the Medicare GLP-1 Bridge program.
Right, the bridge.
We are going to figure out who actually makes it through the incredibly tight clinical filter to qualify, the hidden financial potholes that could completely wreck your retirement budget, and why a much broader permanent rollout for these drugs just hit a major structural roadblock.
Yeah, and to really grasp why this bridge program even exists and why it's so incredibly complicated, you have to look at why that door was locked in the first place.
Let's go back to that.
So when the Medicare prescription drug benefit, which you know is Part D, was written back in 2003, lawmakers included a very specific statutory prohibition.
They basically banned it, right?
Exactly. Medicare Part D was explicitly banned from covering any drug used solely for weight loss.
Which just feels wild today.
It really does.
But, if we put ourselves in the mindset of 2003, GLP-1's like Wegovy or Zepbound, they didn't exist. Weight loss drugs were heavily associated with cosmetic use.
Yeah, they were lumped into the same legislative category as drugs for hair growth or, wrinkle reduction.
Wow, so basically vanity drugs.
That is the core of it. The medical consensus, and therefore the legislative consensus, treated weight loss as ancillary to health, not fundamental to it.
Right.
So for the last couple of decades, your diagnosis dictated your coverage.
Let's make that real for a second, just for you listening. If I had type 2 diabetes and my doctor prescribed me a GLP-1 medication, my normal Medicare Part D plan would cover it.
Right, because it was treating the diabetes.
Exactly. But if my primary issue is obesity and my doctor prescribed the exact same class of drug to manage my weight and prevent future health issues, Medicare would reject it.
And you would be on the hook for a cash price that could easily exceed, $1,000 a month.
Which is just staggering.
It is. But that dynamic began to shift recently under a new Trump administration initiative, because changing that original 2003 law requires an act of Congress.
Which, takes forever.
Right. So the Centers for Medicare and Medicaid Services, CMS, had to find a creative workaround. They launched the Medicare GLP-1 Bridge.
Okay.
This is a temporary pilot program established using something called Section 402 Demonstration Authority.
I saw that term in the sources, Section 402. Can you explain how that actually works? Because it sounds like some kind of legal loophole.
It's essentially an experimental bypass valve. Congress gave Medicare this authority so they could test out new ways of paying for healthcare or delivering services.
Well, without having to pass a new law every time.
Exactly. It's a sandbox.
Yeah.
Under Section 402, CMS can temporarily waive certain statutory rules, like the ban on weight loss drugs, to see if a new approach improves care or saves money.
So they are using this sandbox to bypass the ban, and they officially launched this on July 1st, 2026.
That's right.
The sources note it covers FDA-approved weight management GLP-1s, specifically highlighting Foundayo, Wegovy, and Zepbound.
Yeah, though for Zepbound, it's only the quick pen formulation, not the single-dose vials.
Good to clarify. But here is the part that jumps out at me. It is currently scheduled to run only through December 31, 2027.
Yeah, just 18 months.
18 months. If you are a patient who finally gets access to a drug that alters your metabolism and requires long-term use, an 18-month window is terrifying.
It really is.
What happens in January 2028?
It's a very real, very pressing concern. Because this is a demonstration project, its future is inherently uncertain. The government is essentially saying, we need to gather real-world data.
Data on costs and usage, right?
Yes, they need to see how many people take this and how much it costs before they commit permanently.
Wow. So if you start this medication now, you must have a frank conversation with your doctor.
You have to. You need to discuss what the exit strategy or transition plan looks like if the program just vanishes in 2028.
I want to make sure I really understand how this is built mechanically because it explains so much of the confusion patients are facing right now.
It is very confusing.
So the bridge is literally bypassing the normal Part D highway. It's a completely separate toll road built by Medicare.
The toll road analogy is perfect.
Right. So your normal Part D drug insurance plan isn't taking on the financial risk for this. They aren't processing the claims, and they don't even have to opt into it.
Nope, they are entirely separate. Medicare set up a single, separate central processor to handle everything.
Okay, so because it is this highly controlled, separate structure, the government has installed some very strict gatekeepers at the entrance.
Very strict. The qualification rules are incredibly tight.
Which we really need to dig into because the headlines make it sound like anyone on Medicare who wants to lose a few pounds can just grab a prescription.
Yeah, but looking at the KFF data, that is absolutely not the reality.
Not at all.
The numbers really tell the story here. When researchers looked at the entire Medicare population, they found that over 13 million beneficiaries met the basic body mass index, or BMI, thresholds for these drugs.
Okay, 13 million.
But when you apply all of the specific clinical criteria required to actually get onto the Bridge program, that number plummets.
How far does it plummet?
Only about 3.8 million people meet every single requirement.
That is a massive drop, from 13 million down to fewer than 4 million.
It is a huge reduction.
So how are they filtering out 9 million people? Let's walk through those clinical criteria so you, listening right now, have a sense of whether you even make it to the starting line.
Well, first, the non-negotiable basics. You have to be 18 or older, and you must be actively enrolled in a Medicare Part D plan.
Even though the Bridge operates separately.
Exactly. You still have to have standard drug coverage to participate.
Interesting.
Then we get to the clinical weight tiers. The most straightforward path is if you have a BMI of 35 or higher.
Okay, so BMI 35 is the top tier. But what if your BMI is lower?
You can qualify with a BMI of 30 or higher, but only if you also have at least one specific comorbid condition.
Like what?
The program lists severe issues like diastolic heart failure, uncontrolled high blood pressure, or chronic kidney disease at stage 3A or higher.
So they are essentially saying if your BMI is 30, we aren't covering the drug just for weight loss. We are covering it because your weight is actively exacerbating a serious, immediate health threat.
That's the underlying logic. And they take it one step further.
No, there's more.
Yeah, the lowest weight threshold they will consider is a BMI of 27. But at 27, the accompanying conditions have to be even more specific and critical.
Like a previous heart attack or something.
Exactly. Prediabetes, a previous stroke or heart attack, or peripheral artery disease with symptoms meaning blocked arteries in your legs or arms.
It really sounds like the government is rationing the drug based on immediate risk.
They absolutely are.
They are targeting the people who are statistically most likely to cost the Medicare system a fortune in emergency room visits in the near future.
That is a very astute way to look at it. And it's not just a matter of checking a box on a form, you know.
Oh, I'm sure it's not.
Your healthcare provider has to submit a prior authorization.
And we should clarify for anyone who hasn't dealt with this, prior authorization isn't just a quick phone call.
No, not at all.
It is often a massive bureaucratic hurdle. It means your doctor has to submit clinical proof like lab results, chart notes, proving you meet these exact metrics.
Right. And the sources point out your doctor also has to certify that the GLP-1 is part of a broader lifestyle program focusing on diet and exercise.
So you can't just get the pen and do nothing else.
Exactly, which is an important clinical safeguard. But there's another massive restriction here, which goes right back to that locked door we talked about at the beginning.
Ah, the two doors concept. I love the way one of our sources framed this, and I want to share it because it makes the bureaucracy crystal clear.
Go for it.
So imagine two 68-year-old neighbors. They are taking the exact same GLP-1 medication. Neighbor A has type 2 diabetes. She uses the normal Part D door.
Right, the main highway.
Her drug is covered the traditional way on the main highway. Neighbor B does not have diabetes. She has obesity.
So she uses the bridge door.
Exactly. She has to use the bridge door, that separate toll road. Here is the catch. If neighbor B tries to use the bridge door because she has diabetes, or maybe moderate to severe sleep apnea, which is another newly approved use for some of these drugs,
she will be rejected.
Rejected completely.
That distinction trips up so many people. The bridge is exclusively for people who cannot get the drug covered any other way.
Wow. So if your normal Part D plan should be covering a GLP-1 for you because you have type 2 diabetes or cardiovascular disease or sleep apnea, you are completely disqualified from the bridge.
Yes. Medicare forces you to go back and use your standard Part D benefits.
All right, so let's play this out. Let's say you make it through the filter.
Okay. You're approved?
You have a BMI of 32. You have uncontrolled high blood pressure. You don't have diabetes. Your doctor wins the prior authorization battle, and you finally get approved.
It's a huge victory.
You walk up to the pharmacy counter. The headline feature of this program, the thing everyone is talking about, is that it costs a $50 monthly copay.
Which sounds great.
Honestly, considering the cash price is astronomical, $50 sounds like an incredible deal.
On the surface, it provides immediate financial relief. But this is exactly where the mechanics of that separate toll road create some deeply frustrating financial realities for patients.
Because of the separate system.
Yes, because the bridge operates completely outside of the normal Part D system. The way that $50 behaves is entirely different from every other medication you take.
Right. So because it's a toll road, the money you pay there doesn't get reported to the main highway.
You've got it. Which leads to the first major financial consequence.
It is.
That $50 copay does not count toward your standard Part D deductible.
Wait, really?
Really. If your normal drug plan have a $545 deductible you need to meet before your regular coverage kicks in, the money you spend on the GLP-1 Bridge does absolutely nothing to help you reach that goal.
Which is annoying, but maybe manageable for some. But what about the out-of-pocket cap?
This is the big one.
Because in 2026, Medicare instituted a hard cap of $2,100 on out-of-pocket drug costs. That was a huge legislative win for seniors.
It was massive.
Once you spend $2,100, your covered drugs are free for the rest of the year. Are you saying this $50 doesn't count towards that either?
That is the second consequence, and it is vital to understand. The $50 a month you spend on the Bridge program is completely invisible to that $2,100 Part D tally.
Oh, wow. If you are a retiree on a fixed income, you map out your entire year based on that cap.
Exactly. You count on it.
You might budget thinking, okay, with all my medications, I'll hit my $2,100 limit by August, and then I can relax financially through December.
But if you are on the Bridge, you are paying that $50 in September, October, November, completely outside your safety net.
It fundamentally breaks the predictability of the new Medicare drug cap.
It does. And the third consequence might be the most heartbreaking.
Let's hear it.
There's a program called the Low-Income Subsidy, often referred to as extra help.
Right, which helps with drug costs?
It dramatically lowers drug costs for Medicare beneficiaries with limited income and resources. They might pay just $3 or $4 for a prescription.
Here's where it gets really interesting, or honestly, incredibly frustrating. Because this is a separate toll road, the low-income subsidy doesn't apply to the Bridge, does it?
It does not. The policy dictates a flat $50 copay.
So the people who need the most financial help, the folks who rely on extra help for their life-saving medications, still have to scrape together the full $50 every single month for a GLP-1.
That's the reality. For someone on a fixed low income, $50 a month can be a prohibitive barrier.
Absolutely.
It means the very people who might benefit most from this intervention, because obesity disproportionately affects lower income populations, could be priced out of the demonstration entirely.
And what if you don't qualify for the Bridge at all? Or you just can't afford the $50? The sources mention the administration pointing people toward drug discount websites.
Yes. Notably, TrumpRx.gov to compare cash prices.
Okay.
For those seeking alternatives, the administration has directed consumers to use discount platforms to find special offers. However, it's critical to realize that if you use a discount card or buy directly with cash, those payments are treated exactly like the bridge payments.
Meaning they are separate from the highway, too.
Exactly. They are not considered creditable coverage, they will not count toward your Medicare deductible, and they will not help you reach your out-of-pocket maximum.
So you were financially on your own. When you look at all of this, a temporary 18-month program, incredibly strict clinical filters, a separate payment processor, and financial potholes that bypass all of Medicare's normal safety nets.
It's a lot.
It sounds like a complete administrative nightmare. And reading through the sources, it seems CMS knew this was clunky because they actually tried to build a permanent, seamless system for 2027.
They did. They recognized the bridge was just a Band-Aid. The permanent solution was supposed to be the balance model.
Balance, okay.
Balance stands for Better Approaches to Lifestyle and Nutrition for Comprehensive Health. The plan was to launch this massive new model in January 2027.
And that would have integrated GLP-1s directly into normal Part D plans.
Yes, effectively closing the toll road and bringing everything back onto the main highway.
And CMS had done a lot of the heavy lifting. They successfully negotiated a highly discounted net price of $245 per month for these drugs with the manufacturers, Novo Nordisk and Eli Lilly.
Which is a huge achievement.
$245 is still a lot, but compared to $1,000, it's a huge discount.
And the balance model wasn't just about the drug, right?
No, what made Balance unique was that it required the drug manufacturers to provide lifestyle support programs.
Like diet and exercise.
Exactly, focusing on diet, exercise, and medication adherence at no additional cost to the patient. It was a holistic, comprehensive approach to obesity.
It sounds like the dream scenario. Lower negotiated prices, integrated into Part D so your deductibles and out-of-pocket caps actually work, plus free lifestyle coaching.
It was very ambitious. But it didn't happen. The plan derailed. Why?
It came down to a fundamental fear of financial risk. The balance model was voluntary for the insurance companies that run Medicare Part D plans.
And they have to agree to it.
Right. CMS needed an 80% participation rate from these plan sponsors to move forward. But right at the deadline in April 2026, the insurance plans balked.
Let's do the back-of-the-napkin math on why they balked.
Right.
The estimates for covering obesity drugs under Part D ranged from $25 billion to $35 billion over 10 years.
Just massive numbers.
If you take that 3.8 million eligible people, multiply it by $245 a month, month after month, the numbers are staggering.
The scale is unprecedented. Part D plan sponsors were terrified of absorbing that massive financial risk.
Sure.
They didn't have enough long-term data to predict exactly how many people would actually take the drugs or how long they would stay on them.
And if an insurance plan absorbs billions in new drug costs, their only recourse is to raise monthly premiums for everyone on Medicare.
Exactly. And if they raise premiums too high, seniors will drop their plan and switch to a competitor.
It's a completely asymmetrical risk for the insurance companies.
Which is why they backed out. So without the plans on board, CMS had to indefinitely delay balance for Medicare.
And they were forced to just extend the clunky temporary bridge program through end of 2027.
Yes. But one of the most fascinating details in the KFF brief is that while Medicare hit pause, Medicaid is actually moving forward.
Really?
Yeah, it is a striking divergence in American healthcare policy. From May 2026 through December 2031, state Medicaid programs have the option to participate in the balance model.
So they get the deals?
They will get access to that confidential, discounted $245 pricing for GLP-1s, and they get the manufacturer-provided lifestyle support programs.
But Medicaid is a joint federal and state program. So even though the federal government is offering this, the individual states have to choose to participate.
Right.
And state budgets work very differently than the federal budget. States generally can't run deficits. They have to balance their books every year.
Which is the hidden catch here. Participation is optional for the states. Many states are currently facing severe budget shortfalls and federal funding cuts.
So they might not be able to afford it.
Exactly. Even at a heavily discounted price. Offering GLP-1s to millions of eligible Medicaid enrollees represents a massive new line item in a state budget.
Wow. So if a state opts out because they simply can't afford the upfront cost, their Medicaid populations won't see this expanded access at all.
If we connect this to the bigger picture, what's fascinating here is that Whether we are talking about Medicare insurance plans bailing out or states agonizing over their Medicaid budgets, we are really just watching the entire healthcare system struggle with the same fundamental economic tension.
The cost versus the benefit.
Exactly. On one side of the ledger, you have the immediate, undeniable, multi-billion-dollar upfront cost of prescribing these medications to tens of millions of people. It is a shock to the system.
A huge shock.
But on the other side of the ledger, you have the potential long-term downstream savings. If you treat obesity effectively today, you could theoretically prevent countless heart attacks, strokes, joint replacements, and cases of kidney failure tomorrow.
But the system is struggling to balance the budget of today against the potential health of tomorrow.
Perfectly said.
A Medicare plan doesn't want to pay $3,000 this year to prevent a heart attack that might happen 5 years from now, especially if that patient might switch to a different insurance plan by then.
And that misalignment of incentives is exactly why we are stuck in this weird, highly restricted middle ground phase.
Which perfectly explains the reality we are living in right now. Let's do a quick recap so you have the essentials of navigating this middle ground.
Sounds good.
First, the Medicare GLP-1 Bridge is open right now, but it is a temporary pilot scheduled only through the end of 2027. Second, to get on the bridge, you must meet very strict BMI and health criteria, and you cannot be eligible for the drug through your normal Part D plan for something like diabetes. If you thread that needle, the copay is $50 a month. But third, and most importantly, you have to remember that $50 sits entirely outside your normal Part D tracking. It won't help your deductible, it won't help you reach your $2,100 out-of-pocket cap, and the low-income subsidy does not apply.
And we must emphasize that our deep dive today is strictly for educational purposes. We are untangling the policy and the financial mechanics of a very complex system. This is not medical advice.
Absolutely not.
If you think this program might apply to you, your next step is a dual approach. You need a clinical conversation with your doctor about your BMI, your comorbidities, and the prior authorization process.
And then the financial side.
Right. You need a financial conversation with a Medicare broker to understand exactly how that $50 toll road interacts with your specific retirement budget.
You absolutely have to know the rules of the road before you start paying the tolls.
I'd like to leave you with a final thought to mull over.
Please do.
Throughout this discussion, we focused heavily on the mechanics of the GLP-1 Bridge as an administrative workaround. But if you look at what the delayed balance model was trying to achieve specifically by mandating that manufacturers provide lifestyle support programs alongside the medication, it points to a profound evolution in medical philosophy.
Moving beyond just handing someone a pill or a pen.
Exactly. The future of medicine in this space isn't just about handing someone a prescription pen and sending them on their way. It is about redefining obesity entirely. We are shifting from a paradigm of personal lifestyle failure to recognizing obesity as a complex, chronic disease that requires holistic, lifelong management combining powerful biochemistry with dedicated behavioral support.
Which changes everything.
It does. If Medicare eventually figures out how to fully integrate that philosophy and absorb the cost, how will it change our entire healthcare system's approach to preventative care?
That is the multi-billion-dollar question. For 20 years, Medicare kept that door firmly locked, treating obesity as something completely outside the realm of medical intervention. Now they've cracked it open with this temporary bridge.
Just a crack. For now.
But if they finally figure out the math and open the door all the way, it won't just change the lives of the patients who walk through. It might just change the foundation of the entire healthcare house.
Thank you for listening to the Next Chapter Retirement Podcast. Please like and subscribe and share this with anyone planning their next chapter. For help navigating Medicare, you can find helpful resources and connect with our team at nextchapterpod.com. Until next time, plan wisely and live fully.